Good afternoon. I am Delaware State Representative Paul Baumbach, serving the 23rd House District in Delaware, which is Newark, Delaware, the west and north side of town. And I also serve as the co-vice chair of the Delaware Retiree Health Care Benefits Advisory Subcommittee, which has been exploring what health benefits we provide to our retired employees both now and in the future. And those who have been tuning into these updates know the history of what's happened in our state. About 2 years ago, the State Employee Benefits Committee made a decision that the health benefit for upcoming, as in imminent, retirees was going to be changing from Medicare Supplement to a version of Medicare Advantage. And there was uproar and a lawsuit, and a Superior Court judge postponed the implementation. And during that postponement, that stay has remained in place. And the legislature created this advisory subcommittee to explore all these elements and to come up with recommendations of how to address healthcare benefits for our retirees. And of course, very important to point out is that the reason this is very important, not only is it important for the retirees, it's important to the state because we've made these promises and we've not backed it up with money in the trust fund. So we have to address the shortfall there. And we've been doing that. We've had a gazillion meetings. That's a very official measurement term of gazillion. But let me show you what I mean by that. I always do a Google search to find this magic page, and I put in Delaware SCBC subcommittee's material. And then I come down and I say, I want to see the Retiree Health Care Benefits Advisory meeting materials. And let's start looking through the meetings. So March 6th, March 16th, March 22nd, March 27th. So that's 4 meetings in 1 month. April 3rd, April 17th, April 26th, 3 more, we're up to 7. May 8th, May 19th, just 2 there, we're up to 9. June 6th, June 26th, July 10th, July 20th, August 10th, August 24th, September 8th, September 27th, October 26th, November 28th. That's what do we got here? 16, 17, 18, 19. We'll have 20 meetings by the end of the year. That's a very active subcommittee in 10 months to have 20 meetings. That's what's been going on. So we had a meeting this week on the 28th, and I'm going to say our last meeting is on Wednesday the 20th from 10 a.m. to 1 p.m. And I don't recall yet where the location is, but we will see that announced shortly. And what you have here, if you look at this week's meeting, we have the agenda. I'll look at that in a second. It was recorded, and that recording is already posted. So if you missed it and you want to catch the recording, which should be both audio and video, we've got a link for that. We've got a draft report. So we did a very, what I call a skinny report in late April and shared that with the governor at the legislature. And now this is a interim report. I view it as it's the year-end 2023 report. We'll look at that in some detail. And then we had 2 different things to look at, and we'll look at all these in detail. Both of these came from me. I'm one of 15 members on the subcommittee. And actually all 3 things, because we have the draft one and then the final one. We're just going to look at the final one. And then something that was discussed, but no action was taken on it yet, was a motion that committee member Wayne Emsley brought up. So let's start at the agenda. And it's the normal call to order. You review the minutes, discuss some pricing, and we'll get to that. And looking at both benefits for retirees who are not yet 65, not yet eligible for Medicare, those who are 65 plus eligible for Medicare. Talk about a consolidated motion. We had a lot of issues we want to go through, and we thought the best way to do it was try to create a single motion that took them all together. You can call it an omnibus motion, and see if we can get one vote to get it all done. So that's what we aim to do. And then we had public comment before we voted upon it. And we came back and did a vote on that. And then we looked at the report, and we're working on finalizing that. We should get the final touches in next month. Sorry, later this month on the 20th, and after public comment, hopefully, and then get those recommendations off to the General Assembly and to the governor. So this is the first handout that we went over. I prepared this. This first column here is currently you have this Medic-Fill system, and the average retiree who uses it on average of 50th percentile within the range of people who utilize their healthcare a whole lot, and those who use it very little. You can view it as maybe the healthiest and the least healthy. Well, we're looking at the average. Pays about $669 per year, and the state pays about $5,236. Now, they pay $669 for this plan, but this plan is just this is age 65 plus. One reason why that amount looks pretty low is that this is a Medicare eligible individual who's paid into Medicare all their life, and traditional Medicare pays for about 80% of benefits for somebody who's Medicare eligible. So for the amount on top, that last 20%, it's about $669 out of pocket for the retiree. And it's a little bit less for the healthiest, about $474, a little bit more expensive, about $800 a year for those who use the 90th highest utilization of the retirees. So that's what we do under Medic-Fill. And what we're looking at is, well, one thing to do some savings for the state, but do it reasonably for an impact on retirees, is to have offer two options. You can think of great and little. The great coverage would be the G coverage, so it's more comprehensive and more expensive. And the lesser coverage, the L coverage, costs less but covers less. So what happens if we have the retirees, and this is a retiree who has put enough years in to get the maximum state coverage, or 95% of the premium. They were paying 5% and 5%, and these two columns is, I'll say, a single option. So at a 5% pay, then if you look at, the state's going to save $238 a year for those who choose G, and they'll save about $900 a year for those who choose L. And what will the retiree pay more than what today's retirees pay? They'll pay about $200 a year more if they select G. If they select L, and if they're on the more healthy side, they'll pay about $180 more a year. And if they're on the very unhealthy side, they pay about $1,500 more. You can look at this and say, L is not a good choice if you are on the less healthy end of the spectrum. But you can see that, again, L is better if you're on the very healthy end of the spectrum, and not a big difference at the 50th percentile. So that was one choice. I also presented a 7% share for the retiree for G and a 0% share for L. Because L is a lot less expensive, I was proposing the state cover all that cost, 100% of it, but then pass a little bit more of the cost of G onto the retiree. So you can see that the state would save a little bit more for those who choose L, and a little bit less for those, a little bit more for those who choose G, a little bit less for those who choose L, and it's a little bit more for the retiree who chooses G. But you can see it's notable savings for those who choose L. And then another one is, what if we had the retiree pay 9% for G and 0% for L? Now, I should have led with one thing. This is for non-grandfathered retirees. And as we are defining it here, as the subcommittee has agreed upon, a non-grandfathered retiree is somebody who hasn't even begun work for the state yet. It is somebody whose first day of work for the state is in 2025 or after. So if you are a current retiree, or if you are a current employee, when you become Medicare eligible, our recommendation is no change. You're going to get this column. Okay, grandfathered, you're going to get something like Medic-Fill. And it's only for those who are non-grandfathered, those who haven't even begun work yet for the state, who would have the change to one of these three columns. And I'll jump to the end of the book. And as a subcommittee, we chose this column where it's still that 5-95 split between the retiree and the state for the premium. So I wanted you to let you know what was happening there. So this is the final motion that we passed. And so let me go over the elements. This is, yeah, there's like 7 different elements here, I guess 6. We had a lot of what I call loose ends, and I was trying very hard, as were other members of the subcommittee, to get these all tied together so they can go into the late December report and go to the governor and the legislature in January for action. So one recommendation is that there is a formal funding policy by the State Employee Benefit Committee for funding non-pension employee benefits. So, which is like retiree health benefits. We're already doing the 1% of budget. That was done. We recommended it in April. The legislature took action in May and June. It's now law. So that does a good job of filling a good part of the gap of funding, and it'll take years and years to have the full desired effect, but it'll help tremendously. We're also proposing that the OEC contribution, which is it's not a payroll deduction from the employee, but a payroll deduction from the state for state employees, and have a growing percent of that go towards the trust fund to help fill it up, and have it done in a very gradual manner that does not overburden each year the change, the increase that would go towards the trust fund. So that first thing is the funding policy, and we would like to have a formal policy, because what we've learned is that the powers that be, the people we answer to, and that's the bond rating agencies, when they look at states, they look at their obligations, they look at the trust funds, they want to see if there's a formal policy and that is followed. So this will, we believe, will be beneficial to our state to do that. Let me make it bigger so you can read it. There you go. Okay, second piece is the healthcare pricing reduction proposal. So this is one where the state, through a lot of different task forces and research, has found that healthcare is very expensive in Delaware, more expensive than our neighboring states, more expensive than many states, and we'd like that fixed. We don't necessarily need it studied more. We've really done a lot of studying. We also have several states that have taken steps to address this. Indiana, Oregon, Maryland are 3 examples. And so what we're asking is that the General Assembly and the governor immediately and effectively address healthcare pricing, both inpatient and outpatient costs. So that is something that, and we talk about leveraging the power of the state. We have a lot of healthcare we deliver to our employees, to those who are eligible for Medicaid, and that is power. When you're an employer with that number of employees and you're working with the health insurance companies, you've got some leverage. So let's use that leverage. And we also are sensitive to the fact that this impacts private employers in our state also. So we're going to be collaborating with employers and Delaware residents, and we're looking for transparency, consistency, affordability, and sustainability. The third piece is there are 3 classifications of those who the state provides healthcare for in the employee world. One is the current employees, and the second group is retired employees who are not yet eligible for Medicare, and then those who are Medicare eligible. And what we found is that when the state says, well, providing this to you, it's going to cost us so many dollars per employee, or younger retiree or older retiree. And what we find is those numbers, the quotes for what those premiums aren't terribly reality based. So what we're recommending is the SEBC study that closely and come up with what true costs should be. What we found is that they're, quote, overcharging the age 65 plus retirees and undercharging the sub 65 retirees and current employees. And it's not that we want to make dramatic changes all of a sudden and have the 65 plus pay a whole lot less and employees pay a whole lot more, but we do think that we should get them towards equity, fairness. So that is that recommendation. We had, and I'm going to say this is from, be thankful to, appreciative of our union members on the subcommittee. Sorry, I have to drink some tea here. One of the things to save costs in the future is that we're extending how long you have to work in order to get different levels of state covering your retiree health benefit costs. Currently, these, whether you get 0%, 50%, 75%, or 100% coverage, is currently under 15 years, 15 to 17 and a half, 17 and a half to 20, or more than 20. This adds about 2.5 years to it. So less than 15, 0. If more than 15, but less than 20, you'll get 50%. If you have 20 to 25, you have 75%. Now you have to work 25 years if you start work 2025 and beyond, to get that 100%. But again, if you're a current employee, the previous version, which was in place when you started your job, is the tier, is the structure, is the schedule that applies to you. But we're recommending that for new employees, you've got a longer period of time before you get to that 100% level. Retiree coordination of benefits. We have what's known as a spousal coordination of benefits. So if you are an employee or a retiree and your spouse is typically eligible for healthcare benefits, you have to first verify that your spouse is not covered by another plan. Maybe they have a job where they have health benefits, in which case the state would not want to pay for benefits for the spouse because the spouse has it elsewhere and would save the state some dollars. So that program is in place. Not perfect, but it's there, and it often works. And what we're recommending is that we start having retiree coordination of benefits. So not only spouses, but what if the retiree? What if you retire from the state after 22 years, and you're getting health benefits, but you take another job and it has health benefits? We don't want the state to have to pay for your benefits during your time while you're working for this other employer who provides health benefits. So we think that's a potential for savings, and so recommending that. And then the last part is related to that table that I had up a second ago. Sorry, let me get my mouse in the right area. There we go. Remember that table? Okay, so the last thing says we're going to do a 5/95 split for both a G-type plan and an L-type plan for those who are first employed by the state on or after January 1st of 2025. So this one motion, and can I do it that way? There. This one motion was passed with a single vote. So the subcommittee said, well over a majority of the members said, "Yep, we like this." So that was done on the 28th, and then that brought us to the report. This is, I have a newer one, but let's not worry about that. This is going to be posted more than a week before the meeting on the 20th, and the public is invited to submit their questions and comments in advance. Also, we'll have a period of public comment at the meeting on the 20th, which you can attend and speak virtually or in person. If you submitted your comments in advance, the subcommittee would have the opportunity to review those ahead of time. And it goes over the history, and it goes over membership, and it goes over what the heck we've done over the past year, and then shows the areas of focus. Talks about the request for proposal. We'll go for that in a second. Oh gosh, I really do need the other one. Let me see if I can pull it up. Get it over here. Dun, 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 dun. Okay, so sorry, I should have thought about this one ahead of time. Here we go. Okay, updated report. So I have an updated one, and I think it's important to get this one. So I'm going to download that. And there we go. Okay, so this is the updated one. So let's just sort of jump through it. I really want to move through. It goes through a bunch of the history. It lists all of the actions and recommendations that we've made, including the ones that were made on the 22nd, and we don't need that ad. Working through the recommendations, get some background, talks about the membership. There we go. Okay, how far did we go forward? What are the things we looked at? Different tasks we worked on. Let's move through a whole bunch of stuff there. Goals established, studied areas of focus, funding options. We reviewed a whole bunch of different things, plan design, etc. RFP update. So the RFP stands for request for proposal. I do want to see that in case there's any questions or comments. Okay. And what I should can I make this bigger? Not as easily as I would have liked. Okay, there we go. There was a request for proposal put out by the State Employee Benefit Committee for the next retiree health benefits plan for Medicare age individuals. And 4 proposals were presented by different insurance companies by the deadline, and the 4 proposals came from Aetna, Brighton Health Plans, Solutions, Highmark Delaware, and Trustmark Health Benefits. Finalists will be notified around mid-December, and interviews take place in early January. And all this, we expect a contract award by March 18th of next year. And you can find all this information online. So here are the recommendations that we're making. We've already recommended the 1% of the budget. Recommend that those who are current employees and current retirees may have no changes. They keep getting something essentially identical to the current medic fill and prescription drug benefit program that we're currently providing. No change for, again, current employees or current retirees upon their retirement. Then the next thing we do is that we do not use Medicare Advantage. There's no limit on that. Our recommendation is, this was purely for this RFP process. And this is a recommendation that the SABC did follow of not considering any Medicare Advantage plan. We recommend the SABC have a vote in public on the final RFP. They disregarded that recommendation. We recommend they share the draft final RFP before the vote, before it was approved. They disregarded that recommendation also. And we recommended that the RFP is provided to all members of the subcommittee as soon as practical after approval. I don't remember if that was, I can't say one way or the other if they did that. Current contract was originally bid for a 3-year term. We recommended this also be done on a 3-year term. They disregarded that and had it for a 2-year term instead. And we also said that any changes in plans should not apply to current employees or current retirees, only those who are hired on or after January 1st of 2025. And then at the meeting this week, we recommend a few more things, including the written OPEB funding policy, checking the pricing of the 3 different subgroups, as we went over before. We also have recommendations to the governor and legislature. The 1% of the budget has already been done, and already did that. Also, we talked about the OEC percent of payroll and have it go from the current, it's like 0.36%, boosted to 0.50% in the upcoming budget year, and then add 0.25% every year thereafter until we do the crossover point where we have enough money set aside. And then additionally, we have the recommendation of the looking at healthcare pricing in Delaware and take steps to get that coming down and more in line with our neighboring states. Also, that we adopt changes so that if you are hired on or after January 1st, 2025, you know that you're going to need to work 25 years to get the maximum coverage of your healthcare by the state of Delaware. So this new schedule will be in place in time for people who are considering employment on and after 2025 to know what it is, so it's not changed on them partway through. And we recommend that retiree coordination benefits, so that if a retiree takes another job after they retire from the state, even if they're eligible for healthcare benefits, if they're getting it from their new job, the state wouldn't be on the hook while that person is covered by that new job. And last one is that we recommend that for non-grandfathered, so new hires, once they become retired and once they're Medicare eligible, that the state would provide something similar to what's currently in Medigap G and Medigap L at a 5/95 split. And then there's some more work. And that is the report, along with a whole bunch of appendices that can just sleep. So get that piece out. That's the report. And then at the end of the meeting, our committee member, Wayne Emsley, put forward this motion. Another drink of my tea. And Wayne's concern is that we've heard pretty loudly that employees and retirees feel confused about what they can depend upon. And so what he would like, if you jump to the therefore, that legislation is drafted and passed that clarifies whether or not health benefits that are in place at the date of hire or the date of retirement shall be provided for the lifetime of the retiree and eligible spouse. So what he's asked for is that we pass a law that says we can't change your retiree benefits once you're in the system. So you'd like to see it clarified, and I certainly understand that. And then also that administrative procedures are developed so that this is communicated effectively with the employee/retiree. So that was what was done at the meeting this week. And let me see, I only have one question. Once voted on, will this become a part of the state of Delaware code, such as Title 29 that expired 12/31/22? So Anne Marie, if you can indicate what you mean by this, when you say, will this become part? This report that goes to the legislature, the design of it is that it goes to the legislature, and the legislature will then, that's not what I want, that's what I want. So the parts that, just to make sure this is the right one, this is the, yeah, okay. So for instance, what, when we have recommendations to the legislature, we will go through here and figure out for these ones which require, you need to determine which of these recommendations require a change to the law. And that means that, and I think it's going to be the 4 members of the legislature who serve on the subcommittee, which is my fellow co-vice chair, Senator Brian Townsend, who is the Senate Majority Leader. And it means that Senator Brian Pettyjohn, who is the Senate Minority Leader, I believe, and also my colleague in the House, Representative Michael Ramone, who is the House Minority Leader. The 4 of us and other colleagues work on the bills to put this in place. That is the recommendation of the RHBAS. 4 of the 15 members are legislators, and therefore, I think that's our step. I'll say the baton to me, with this issuance of this report and delivery to the General Assembly, I think the baton has been passed from the RHBAS to the legislature. And that is something that I'll be speaking to my colleagues shortly to get that moving. Given that this has already been, the motions have been passed, just the report hasn't been finalized, I think we can be working on this right away. Okay, so what actions are you foreseeing in January? Pat, great question. I do want to, I'll let you know, this is the subcommittee has been working on this very obviously. It doesn't mean that there's not what I'd say adjacent issues that I think warrant legislative action. And I have several pieces of legislation prepared along those lines. So that is, so I have that done. Now that we have the final recommendations for 2023 from the RHBAS, we'll have additional pieces of legislation to be done. And so I think in January, number one is we're going to have some bills introduced, maybe a bunch, on the order of, I've got 3 already, maybe another 2 or 3 from this set of recommendations. And then I think they'd be introduced in January. It wouldn't surprise me if we had committee hearings on them and maybe even pass the chamber, whether it be the House or the Senate, depending on how it's designed. So I think you're going to see action in January, and then it's going to depend on where the votes are. And we also need to, the process is such that it needs to pass both chambers with a majority, as long as it doesn't affect tax rates, in which case you have a supermajority requirement. So it needs to pass both chambers, then it goes to the governor, and the governor can choose to sign it or not sign it, let it become law, or to veto it. And if it is vetoed by the governor, then the legislature has the opportunity to override the veto. So that's the process, and we will see. I think that I'm going to say I think that the recommendations from the RHBAS, by their nature, by the deliberative nature, by the consensus nature, by the broad stakeholders at the table as voting members of the RHBAS. I think that these steps should be pretty easy to implement and to get through the legislature and approved by the governor. Anything that's not a direct recommendation of the RHBAS is not as automatic a likely successful candidate, so that could take additional work. I think that the public will hear more about that later this month. Okay, other questions? Thank you, Lynn. I appreciate that. Given the governor's stance on Medicare Advantage, what do you anticipate will be the governor's take on all this? My sense is that by August of this year, the governor and his administration recognized that Medicare Advantage was dead on arrival in Delaware, and I don't think that his administration is looking to beat a dead horse. I think Medicare Advantage as a Delaware State employee, Delaware State retiree health benefit is not going to happen on his watch. So I'm not expecting there to be an undue barrier to getting these recommendations through the governor into law. That's my take. I've been wrong so many times, but that's my best take at this point, is I think these recommendations should fly. Anything beyond recommendations that came through retiree health benefits is less of a odds-on favorite in getting through the administration. But a lot of it depends on if it goes through the legislature with a large number of votes, I'll say a veto-proof margin, then it's I'm taking your words, Pat. I would anticipate that the governor would sign the bills into law. So if and I'm never running for governor. I mean, yes, it's on the record. If I was governor, I'm not going to be vetoing bills that I know can be overridden. It's just not. It's not a common practice, and it's not a recommended practice. So you veto bills that barely got across, and that you think your veto will stand up. So, and none of these recommendations. I think these ones should pass with a large margin. And this motion passed with an affirmative vote from at least one of his cabinet secretaries. So I think we're in on a good path with these recommendations. I think these recommendations alone are good. I have some additional changes that I'd like to see that I think will make things even better. And but we'll see how that turns out. Stay tuned, as they say. I'm not seeing any more questions. Again, remind you the next meeting of the advisory subcommittee is the 20th. I think that's a Wednesday, from 10 a.m. to 1 p.m. And the main task of that meeting is finalizing the report so it can be sent to the governor and the legislature. Also, I think part of that is figuring out what the heck we're going to do in 2024. I'd imagine that we will be shifting to monthly, bi-monthly, or quarterly meeting schedule. But I think we also want to lay out what is our role going forward. This, especially in my eyes, tying all this together, tying all these loose ends together at this week's meeting, I think has really done a nice way of ending that chapter for the subcommittee. So I think we need to figure out what is the role, if any, going forward for the RHBAS. I know a lot of people have been very appreciative of the transparency that the RHBAS has brought to this exploration discussions, and has seen it lacking in some other processes, and would like to see it continue. So, but we need to figure out, okay, we can operate well, but what should we be operating well on? So that's what I think we'll be talking about also on the next meeting on December 20th. You're most welcome. I've been enjoying this. Does a new legislation have to pass to not sunset the RH? Great question. The RHBS has no termination date. It's an open-ended subcommittee. The legislature can shut it down legislatively. It, I think, on its own could sunset itself. Sort of say, we're not going to meet again. That's sort of sunsetting yourself. But the legislature doesn't need to act to have it continue to work. Given that the quote, the next retiree benefit plan for Medicare eligible people that is underway and likely doesn't. I mean, frankly, I think one concern maybe is being a watchdog for the current RFP, request for proposal process, the bidding for the next plan, and having the RHBAS be a watchdog over that process, over the SEBC's implementation of that process. That may be something that we want to sort of assign to ourselves for 2024. And I think that'd be pretty appropriate. I think frankly, the effort of the healthcare pricing and having, I'll say, again, watchdogging that process and giving input if we think maybe it's not going the direction that we had hoped for. I think that could be another function for the 2024 version of the RHBAS. So we'll see. Are you also looking at Healthcare Cost Oversight Committee? Yeah, Pat, that's exactly what we have in here. If you look at sure, I have it on my screen. You don't have it on your screen. That doesn't help you very much, does it? So if you look at point 3 here, we advise the General Assembly and the governor immediately and effectively address the issue of healthcare pricing in Delaware, including statutory, regulatory, and administrative changes in 2024. We're talking about quick. Let's get this done. To bring more transparency, consistency, affordability, and sustainability to healthcare prices and price growth for Delawareans and Delaware employers, including the measures from the General Assembly and the governor should be utilizing the contracting authority of the state. We've got the ability to contract to obtain healthcare benefits for our employees and our retirees and our Medicaid members, and that's a lot of people. So use that. Use that authority of the state, including for state employees and Medicaid members, right? And collaborating with the employers of Delaware to require that greater transparency, consistency, affordability, and sustainability. So that we don't have the word task force in there, Pat, as your question had, or oversight committee. One of the reasons is we've studied the crap out of that. So we don't want to create something that we know is going to delay the process where we already have what we typically ask them to do. So we're at the point of saying, let's implement the darn thing. We've studied this, 5 ways to Sunday. Let's get it done. I think that I think the legislature has certainly looked at this deeply, as has the administration, and it's just, well, let's get something passed. Let's find out what needs to change. It's all written down, but we just haven't been able to get the votes for it. So this, I'll say, kicks the legislature in the derriere and says, okay, get off your duffs and get the darn thing done. But in oversight committee, no, we're not. It may be that what they say is you need an oversight committee, okay, and that may be a legislative step that's taken. Maryland, as I understand it, for state employees, state retirees, Medicaid members, they've got a schedule, and it says you as a provider, healthcare provider in Maryland, you can charge, let's say, 150% of what Social Security would pay for a particular procedure, but you can't charge 151%. So it says a certain amount of the Medicare schedule for services, and we're paying in some cases a lot more than that. So a schedule says, yeah, you can charge what you charge to Medicare, which you accept. You can charge a little more than that. We want you to stay in business, but let's not go crazy on this thing because we got to pay those bills, and we're having problems with that. So that's what's going on. A great question. And this issue, I'm going to say, is it's sort of Moby Dick to Captain Ahab. Some of our members who have been on the SCBC for years and part of the Retiree Benefit Study Committee for years have just been in this world, especially some of our labor colleagues. They're so focused on this because they believe that this is the most dramatic improvement we can make to funding our retiree health benefits. More than the 1% of the budget, more than G or L, more than a 5 or 9 or 7% employee share. This, they believe, is where the best savings can come from. So really big initiative, and we're hoping that we can get the momentum that came from the RHB, frankly, came from the frustration over the proposed Medicare Advantage. Let's channel that into this effort, and let's get our healthcare prices down in Delaware. Okay. I think that's it. Not seeing any more questions or comments. I want to thank you for tuning in. It should be meeting-wise, we only have one meeting this month. I think you're going to see some bills coming through, and I think our deadline is Friday the 15th, either Thursday the 14th or Friday the 15th. Some bills should be posted. I'd expect some more in January. So keep your eye out. I likely won't be posting again, maybe even this year in January. If there's something big, I will go through that. And thank you for tuning in. And I'll have this in a format you can share with people who don't use Facebook shortly. Okay. Thank you very much. Have a great weekend, and I'll talk to you later.